So by the end of this presentation, I would expect all those who are present here to at least do some astigmatism reduction for all their cases. Okay. So not all patients need toric IOLs. Not all astigmatisms need to be corrected with the toric IOL. We can also reduce with incisions. Up to 0.5 against the rule can be reduced with a simple up to 3 to 3 mm incisions. Whereas with OCCA, that is clear corneal, opposite clear corneal incisions, we can reduce up to 1 diopter of astigmatism. So always any premium IOL, not only toric, when you are going for any premium IOL, always rule out pterygiums, OSDs, corneal ectasias, and also do a topography whenever needed. Accurate biometry, optical one is always preferred for all these patients. Precise A constant should be used. If needed, you can also go for online formulas. Precise keratometry. For spherical correction, always use the optical biometer. But for axis and the corneal diopters, use either keratometry, topography, or even image guided systems. Or optical biometers also okay. Always take your PCA, that is a posterior corneal astigmatism, into consideration, and also your SIS, surgical induced astigmatism, into consideration. And always see that the patient will have a good vision before you are going for any premium IOLs. Always under promise and over deliver. So what the patient wants is also very important. The patient might want to go for without glasses. You can always go for a trifocal torics if it's suitable, or else you can go for EDOF if needed. And based upon the condition, but sometimes the patient might have some retinal pathologies. We might not go for a multifocal. We can mix and match also. Maintaining toric IOLs is very difficult, so we have to order them in advance. And depending on the various available lenses and options and what the patient wants, we have to order them. Keep always the stock ready for 3-piece and AC IOLs as standby. The spherical equivalents, power, as I told, we can also use immersion. Suppose it's a mature cataract, there is no other option. But I think whenever it is done, it's better to go for an EDOF torics because they have more tolerability. And suppose you have to convert, always keep a lower cylinder lens ready with you. Next tip is that reference marking. That's very important for any toric IOL. So we can use a bubble marker or direct freehand toric marking with a marker. Always see that the patient head is straight. There is no tilt of the face, tilt is not there. The patient keeps on seeing the eye should be looking straight. Then go nearer. And if needed, always use a speculum if the patient is not cooperating. But if you use a speculum, always remove the speculum and reassess your markings, because sometimes the patient will be squeezing their eyes and there might be some amount of torsions. Nasal marking freehand will be difficult, so you have to be a little bit careful. If you are ambidextric, it's even better. Next step, important step, is toric alignment. So once the surgery is over, you place in IOL. Beginners, I would advise you to place under visco. We are usually placing under saline, but initially it's always better to place under visco. Rotate the lens into the position just 5 degrees away from the intended axis, clockwise 5 degrees away from the intended axis. That is because the lenses tend to rotate clockwise, so we have to keep it anti-clockwise 5 degrees away from the intended axis. So the lower one, you can see there is a little bit difficulty in rotating the lens, the haptic, into the bag. In such cases, it is better to use visco to rotate into the bag, dial into the bag. And small pupils, it will be difficult, and also ascertaining the position of the lens will be difficult. So we may have to retract the pupillary margin and assess. For such small pupils, maybe it's better to go for a toric EDOFs, which have better tolerability. So when do you do redial? Suppose we already placed the lens, they had problems, like, or else the pupil was small, we couldn't assess properly. when do we redial? Most of the rotations occur in the first 1 hour. So we usually do under topical anesthesia, reassess the patient within half an hour to 1 hour and see. Suppose there is any significant rotation, we redial on that day itself. Suppose that is not significant, or else we feel it might become better, we wait for 1 week to 3 weeks. And depending on the calculations, we redial the patient. We use this astigmatismfix.com website to assess the amount of redialing to be done. But after 1 month to 6 months, maybe better to consider LRI or OCCIs or even PRK. So most concerns will be whether toric options are available for all types of IOLs. The newer generation EDF, some EDF companies have not yet come with the toric options, but they will be coming in the future. This technology, the people will be asking, it's very expensive, is it worthwhile? Any technology, newer technologies, they are expensive. But compared to the effectiveness of those technology, they are all reasonable expensive. Will the results last lifetime? For torics, we cannot give the guarantee because we have to be aware that all eyes, this astigmatism changes with age, especially against the rule astigmatism keeps on increasing with age. So we tend to overcorrect all against the rule astigmatisms and undercorrect with the rule astigmatisms. So that after maybe 6 months, after 1 year also, the lens will be suitable for that patient. Yes, they can be used for presbyopia and clear lens, but it's always bad, especially initially it's better to go for only the hyperopic patients who are having very difficulty with their glasses. I would not prefer to do in young patients on clear lenses. Cataracts, definitely yes. Should we wait for upgrades? Some lenses are coming with better materials, which have lesser vacuoles, lesser glistenings. Maybe such lenses we can wait, or else the technology is pretty good. We can go for any toric lenses whenever needed. Thank you very much.
I have a question.
No, on the day of same surgery. If there is any residual astigmatism, yes. There are some patients where we had residual astigmatism. Around up to, with OCCI, we can correct up to 0.75 diopters on the table. So we have to take the patient again to surgery if needed for redialing. On the table, we can do. Suppose like one patient we might have seen, I done OCCI while I put an toric lens, because we ordered a lens, but on the day when we calculated cylinder was coming more, we had to go for a 3 diopter lens, but we had a 2.5 diopter lens. So that extra 0.5 we reduced with OCCI.
So one more point is, other than the www.astigmatismfix.com, you can also use the Barrett RX calculator.
Yes.
And you mentioned in the treatment of presbyopia with clear lens, you will not use toric options.
No. We would like to be cautious about that, especially for 0.66 vision.
But you need to use. If it has a corneal astigmatism, then if you don't treat, and for presbyopia correcting, if you are planning treating presbyopia but not treating astigmatism, then it will not.
Not that. I wouldn't like to go for any cataract operation in such patients. That's what I meant.
No, that's okay.
Yeah. I would like to be cautious of operating any clear lens presbyopia patients.
What's your opinion about the hydrophilic lenses with toric?
We have used very few hydrophilic lenses. Some lenses are very good, but most of them like a single piece, you can want to say something? Yes. Plate haptics in some cases might be better, but all these lenses like which are C-loop, it's better to go for this frosted lenses designed with haptics with frosted surface, or those with ridges. The rotational stability will be good. Thank you. Yes. Yeah, that